Thank you, Mr. Chairman. Madam Secretary, not too long ago, HHS finalized a rule, and I think Senator Enzi touched on this a little bit, but I want to just get you on the record on this, that will exempt certain self-insured, self-administered plans from paying the reinsurance tax in 2015 and 2016, which, as it turns out, means that there are going to be a number of union groups who will not have to pay the tax, which would appear on the surface to be a sort of a political favor. As you know, that tax is designed to raise $8 billion in 2015 and $5 billion in 2016. There was a question posed of an HHS official recently in which that person, when asked for clarification on how the change would affect other plans' rates and fees, said it is true that fees will be higher for plans that do have to pay the fee in 2015 because some plans are exempt. And I'm wondering if you agree with that statement, that those plans that didn't get an exemption are going to have to pay a higher fee because the White House's, I guess you'd say, favored groups got a favor.
Well, Senator, I would say that what we did was look at the statutory language and made a determination that the best interpretation of the statute was that any plan that did not have an insurance component or use a TPA should be exempted. Our legal counsel felt that was by far the best interpretation of the statute. This was not a union issue. It was a broad-based issue about self-funded employer plans also, and in order to put out the rule, we determined who would be applicable and who would not be applicable under the rule.
The question, though, is a very straightforward one. I mean, we can dispute.
Well, there's a dollar amount in the statute that
Right.
will be collected from
Right.
those to whom the law applies.
Correct, meaning that those who didn't get exempted will pay higher fees.
Well, there had never been any higher or lower. There were no fees. It was just a definition of who the pool is who is obligated to pay the fees.
But if you distribute that among a certain number of people, and that number of people is now shrunk because of the exemption, is it not true that those who are left in are going to have to pay more?
They will pay the fee as obligated. But again, there was no interpretation of who was in and who was out. We put out guidance, and that's who will pay the fee.
It is a very straightforward question that could result in a very simple answer. I think the answer is yes. I want to ask a question about the 340B program. This last year, Congress has engaged in more active oversight of the 340B program, and I think that all the parties that are engaged in that program want to see it improved and maintained, that there's integrity in the program. It's vital to ensure that that program can continue to benefit the covered entities as well as ultimately patients. And to that end, the Appropriations Act, Consolidated Appropriations Act, provided an additional $6 million in funding to implement new program integrity efforts in that program. And I'm wondering if how these funds are being used. Can you provide information about HRSA's intentions to use the additional appropriations funding? And an example of that, I guess, does HHS is already undertaken audits of covered entities? Are there plans to extend those to manufacturers as well?
Well, Senator, I would say that Dr. Wakefield, who's the head of HRSA and who the umbrella agency over the 340B program, is very much engaged in making sure that the program operates in a more stringent fashion to adhere to the rules. There are audits, as you say, already underway. She has done a couple of briefings for me, and she looks forward to working with Congress to make sure that we are not allocating funds inappropriately, and that the programs entitled to receive the 340B discounts are the ones, in fact, receiving the 340B discounts. So that landscape is being reviewed right now. I can't tell you specifically about manufacturers, but I'd be glad to follow up with Dr. Wakefield and come back to you on that. I think it's safe to say it had expanded beyond its bounds, and we look forward to the opportunity to make sure that we're following the rules, because it's a vitally important program.
It is. Very quickly, CMS's 96-hour rule regarding patient reimbursement at critical access hospitals. Can you comment on that? There are a lot of physicians that we deal with in a state like ours, where we have a lot of critical access hospitals who don't think it's fair to impose that kind of requirement and require essentially physicians to predict the future.
Well, I would say, Senator, this is one that we're getting a lot of feedback and having a lot of conversations. I do come out of a rural state. I absolutely know the vital health care needs that people have and how important it is to have critical access hospitals operate in a profitable manner and stay in the community. So I think the rule was put in place in terms of trying to define an appropriate boundary, but John Blum is having ongoing conversations about whether or not that may be too stringent or too rigid, and so we would appreciate your input and feedback, and as we look toward the future. I don't think the intent from anybody is to damage the opportunity for critical access hospitals to remain in place, but in trying to define what is appropriate in terms of a patient stay, I think was the attempt.
Okay, thank you. Thank you, Mr. Chairman.
Senator Thune, I just want to let you know I'm very sympathetic to what you're talking about. I'm interested in working with you, and it's evident that the administration will work with us as well.